Thank you to all of our speakers for really nice presentations, and I think we touched on all the essential high points. I guess one thing that all of the speakers really touched on was that we don't do surveillance as a hobby. It has to be actionable. We don't just want to generate spreadsheets or even papers. We want to actually be able to have an impact. Speaking to something that Mike Osterholm said earlier, there is a difference between an epidemic and a pandemic, and one of the goals of surveillance, I think, is to move us further to the left of the epidemic curve so that we can actually take actions earlier and prevent an outbreak from becoming a large epidemic or a pandemic, and I think that's evident in what everybody has said today. I would like to invite people to ask questions of our panelists. Please come up to the microphone. Maybe while that's happening, I'm going to ask John a question. One of the things that we at ProMed often get queried about is, why do I have to read all these posts about animal diseases? I really don't need to know about blue tongue, and for example, and what can you help me answer that question, John? How has a One Health approach been actionable? How has it led to earlier intervention, for example?
Larry, that's just me emailing you, testing to see how you will answer that question. I think, one of the great things that ProMed does as a service is it highlights how frequently and geographically, distributed all these epidemics are, both animal and human epidemics, and often they're related. So having a real-time stream of information that reports on sometimes just syndromic or clinical outbreaks in livestock or in animals can be foretelling for something that may happen in human population. There are really knowledgeable moderators that take that information and try to interpret it in terms of what it may mean for risk of human disease, and when there's a human outbreak, understanding that it might have come from an animal population. So you really have to look at animal disease and human disease side by side in many instances, and being aware that there are zoonotic diseases circulating that sometimes might just be apparent in livestock initially is important for shifting that curve to the left and getting ahead of a potential human epidemic as well. So having that information side by side is critical.
Okay, thank you. First question.
Jeff Drazen from the New England Journal of Medicine. So these are very interesting approaches, and I guess the question is, how do you determine when an outbreak actually occurs? It's the Kierkegaardian question, that you live life forward, but you only understand it looking back. And so no one sends you a letter saying that an epidemic has occurred, and if the threshold is set very low, you'll have a lot of false alarms and the community becomes complacent. The threshold is set very high, your outbreak is way beyond control before you do it. So how do you fine-tune it? Can you use the information you're getting to help fine-tune that switch? Because it seems to me that that's one of the critical aspects of pandemic surveillance.
Nancy, this is a real dealing in the real world with flu every year. How do you know when the flu season is starting? How do you know when it's peaked? Can you predict any of it?
Well, the thing about flu is the only reliable thing is how unpredictable it is. And I think last year is a great example of, we kept thinking it was peaking, and we stopped saying that eventually because it kept going up. But I think it's a hard question with flu because pretty much every year we have an epidemic of flu. So part of the answer to your question is that in the context and the situation, you have to fine-tune that differently. And things that are acceptable in one context would never be acceptable in another. And so maybe just to provide as a framing example, back in the 90s, I was working on bacterial meningitis in West Africa and the African meningitis belt. And every year there was what we would have considered an epidemic of meningitis with thousands of cases. But in the meningitis belt, it was just another year. And it really never got attention until 1996. There were 350,000 cases in 4 months. Now, our threshold for what's acceptable for meningitis in Africa, now that we actually have eliminated epidemics, is much different. And that number of cases now would be considered something that would get noticed. Ebola is another perfect example. I think in retrospectoscope, folks would say now that those large outbreaks, if we had behaved as a public health community differently, all of us, maybe some of that terrible outcome would have been prevented. But of course, none of us have hindsight. All we can do is keep taking the information that we have and try to make the best decisions that we can, accepting the fact that we're not perfect. I think the public's acceptance of our imperfections is a problem, because they look at it in retrospectoscope and think, how could you not have known better? And so there's both where you set the dial for public health decision-making, there's where you set the dial for political decision-making, and then there's where the public sets the dial, and those things aren't always the same. And I'm sorry, Larry, that's not a great answer. I think it's a crucial question, but I don't think it's so easy to give a neat answer to.
I'm going to ask also.
Can I refine the question by saying, are the new data technologies that are available helpful in setting that threshold for both knowing what the background rate is and the acceptable rate? Like one case of Ebola, especially a hemorrhagic death, is probably not acceptable.
That's right.
Are the new data that are available helpful in setting that threshold? Because what we're trying to do is we're trying to keep the communities to have faith in the public health and the medical establishment. And is there a way to help fine-tune that issue?
Well, obviously, that's the hope, right? The hope is that we're going to figure out how to make use of all this data to make good decisions. Back in the flu pandemic, the 2009, was really our first experience trying to comb through social media data to see if you could use that data to anticipate flu trends. We weren't sophisticated at it. And the hope is that by using it more and using these data that the modelers here are getting, some of it we look at in retrospectoscope, but the goal of looking at it in retrospectoscope is to be able to predict better. In terms of the public perception, the hard part is that if we're always saying the sky is falling, then nobody's going to believe us next time it's falling. And so I think it's a fine line of putting that data out there, but making sure that the context is understood. And for those of us on the cutting edge of this data, asking the analytic folks to continue to refine the models. The danger is that you use it before it's ready and you make predictions based on data and end up being wrong. The acceptance of that is not so great, but that is the goal, is to continue to figure out how to mine these data sources to make better predictions.
So from a modeling perspective, why don't
Yeah, so I think that, first of all, forecasting is very challenging, and there's a huge amount of uncertainty, particularly we saw this with the Ebola outbreak, particularly whether the epi data is weak or patchy. It's just an analytically difficult problem. However, there have been improvements. The flu forecasting challenges, I think, are a promising kind of way to start thinking about how to engage the academic community and keep them accountable. That's really important. The data sources, absolutely, the new types of data sources absolutely can help, but it will depend on the epidemiology of the disease, the transmission route, all of these basic biological things and how much we know about them. And so I think there is an important exercise that we need to do, which is go through and think about the potentially pandemic pathogens and really systematically figure out what thresholds should be. We can do simulation for this, given different types of epidemiological parameters, and then think about them in different contexts and see where the data gaps are and what we would need to do if we saw X number of cases in X place. That's not something that has been undertaken in a systematic fashion, and I think that would be very helpful in combination with some of these mechanisms for going back and checking the models and improving them. One paradox that we have, and I say this a lot, is that it's not like weather forecasting. If your model prediction is correct and then the intervention takes place, your model's wrong always. So the perfect...
That's the preferred outcome, right?
Yeah. So the perfect forecasting system produces consistently wrong output, and that's just a reality of what we're dealing with infections. But it's something that I think when we're talking about forecasting and analytics, it's important to bear that in mind, because a win looks like a fail.
Thank you. Thanks, Jeff. Mike?
If I could just follow up on that, since I've spent the better part of my career leading outbreak investigations in a state that's pretty well known for its work in early detection. And I think that one of the things that's missing here is, and Jeff, in response to you, it's the human element. I mean, you know, we deal with this in terms of intelligence all the time in the world of human intelligence versus electronic intelligence, et cetera. And I think one of the critical issues here is that we haven't invented a machine yet that's able to actually fully understand that if you add a series of things together, first of all, what kind of disease is it? An enteric disease, a respiratory disease? Is it an environmentally related disease? Is it a disease that shouldn't be found in a given area? What are the numbers? What kind of data do you have on the genetics of the organism? What are the age groups? What are the times? And we often are constantly looking at all of that at a point in time every day. Where public health falls down often is they look at it sporadically and then only then go back. But for example, and Larry and others in the health departments know, Minnesota has been a leader in foodborne disease epidemiology for 30 years and have picked up outbreaks before almost anybody else in the country. And it's because we have a team of people every day that are going through and interviewing people in real time once the sample is found to be positive, and they're doing controls at the same time. And we pick up outbreaks sometimes after 3 people, because we have 3 very unique organisms that are uniquely similar, and we then interview them and find out, oh my God, they all did X, which was the then lead to do further work. So I think part of it is we've minimized the human intelligence piece and what goes into this. And so we want these big data sets. They're nice, they're great, but in the end, they're not what's going to ultimately solve anything. It's going to be the thing. And that's what I worry about is we're losing today, both in terms of federal support, state support, and the idea that this is so important. We get enamored by the machines and we forget about the power of the brain.
Maybe if I could just add to that, you know, there's this truism that's maybe overused, but that, you know, I think is really apropos here, which is that all models are wrong and some models are useful. And I can say that because I'm married to a modeler, so I figure it's fair. You know, one point I think maybe a bright spot in this idea is that flu is a good example where, you know, frequently what we find at CDC is when there's an outbreak or an epidemic, all of a sudden a lot of people build models. And I think sometimes the policymakers not understanding models think that that model is right, not understanding that a model is a tool to help you understand the situation. It's not meant to give you a discrete answer. Because we have such a focus on pandemic influenza and we understand this risk, we've worked with a number of academic modelers, and each of the modelers has their own model. What we do through the flu season is actually pull together a uber model of all the models, with the idea being that the models are going to be refined by each of them looking at how their model predicts the seasonal influenza, so that when there's actually a pandemic, those models are more useful, and so that the modelers actually learn from each other. And I think this is the way in which models are most useful, if you can actually use them in inter-epidemic periods to refine the models, because then they'll be more useful during an epidemic. And also if you can engage the modelers ahead of time so they can actually work with the epidemiologists and the clinicians and the animal epidemiologists to refine those models, so that then we understand what they're trying to tell us during an epidemic.
I wanted to add just one further point too to this idea of intelligence and context. Is we also sometimes are susceptible to assuming that an outbreak of a syndrome is due to just one thing, and we don't. The importance of investigating is to understand whether there might be multiple causes. And an example is in northern India, there's a really high incidence of acute encephalitis. It's a seasonal phenomenon that typically has been attributed by public health systems there to one thing, Japanese encephalitis. Although the problem is only 12% of the cases are laboratory confirmed as JE, which means 88% of them are something else causing the same syndrome or same disease that looks like one thing. And just recently it's been determined that scrub typhus has been contributing to another big chunk of those cases, but still not all of them. So we still don't fully understand what's causing this big syndromic outbreak, although it happens all the time. And that influences your ability to control and intervene and set up appropriate interventions. So that, I think, speaks to the importance of building up diagnostic capabilities. We talked about that earlier, so that you can accurately determine what's going on, which informs your models and helps you, set up better systems. So the importance of diagnosis and really understanding the situation.
Next question.
This is a question for John. We're probably, hopefully within a few decades of having lab-grown meat alternatives that, would essentially be cost competitive with livestock-originated meat. In the extreme hypothetical case where we just say livestock no longer is a thing, how much of the spillover problem would be solved?
That's a great question. I mean, good luck getting people to adopt synthetic meat, but I think a large part would be. In fact, that would solve a lot of our environmental problems writ large. If we didn't have livestock in the equation, that would reduce a good chunk of transmission of zoonotic disease, but not all of it, because people also depend on wildlife as a primary source of protein. So it isn't only grown livestock, but there are entire cultures, communities, countries that get their protein from wild animals. And there's still a risk because as that intensifies, that they're being exposed to more and more diversity of animals. So livestock's part of the equation, but not all of it. Good question, though.
Next.
Hi, Anas Al-Turabi. I've just got a question for the panel about data access and transparency for surveillance and modelling. Caroline, your work shows brilliantly what can happen when you get access to some of this corporately held or privately held data. And it seems that much of our path forwards in improving surveillance is to make better use of linking what might be privately held data. So how do we make that happen? What's in it for me as a private company who has phenomenally sort of detailed high fidelity data on subscribers or customers? What's in it for me to sort of release that data? And what successful examples can you point to of this having happened previously?
And it's not just corporate data, I would add. It's academic data and clinical data and all kinds of data that are held hostage. And how do we encourage the sharing of that of those data? Satchit, do you want?
Well, I think we have to challenge the notion of whether it is their data, right? Does it belong to the corporations itself? And these conversations are happening. And I think using healthcare as a platform to drive that conversation might be the most efficient way to get society to care and invest in that conversation. More recent rulings, whether it is the EU's GDPR or India's Supreme Court ruling that privacy is a fundamental right, will change the tone of data ownership. And certainly public health agencies, both in the European Union and sort of in the South Asian Commonwealth, are thinking long and hard about defining data not in terms of ownership, but in terms of control and access and fiduciary responsibility. So, it is going to be a combination of legal work, ethical and policy combinations. This isn't atypical, right? Always with new technology, societal behavior and law lags behind. This is a known phenomenon, and I think the time is now to start addressing these.
Do you have any ideas on that? How to solve that? You asked the question, yes.
So we do have previous sort of experience with these issues of public gain and private information. I think some of the virus sharing challenges that we experienced through SARS and sort of avian influenza speak to this. And fundamentally, most of these things come down to a just settlement and a just settlement for populations. So I'm just intrigued as to whether it is possible for us to frame things like data ownership as being a public good and there being a public benefit. And there might be market mechanisms for doing that. There might be incentives that come through. But it just feels like part of this is going to be a moral and a legalistic argument. And part of getting that behavior change is being able to point to examples of people having done that successfully, which is why I was particularly interested to sort of hear at the CDC, or Caroline, some of your experiences of getting companies to act this way.
So we've been working a long time on this, and I think one thing is that framing the relationship with the companies and building trust there is really important, because actually we don't want all the data. big data doesn't mean anything, right? You want very precise kinds of information, often coarse-grained. Not necessarily, I don't want to know where each person is, right? So you can develop simple protocols for aggregation that is trivial for them to implement. It's like 3 lines of code, right? It is not difficult, and it gives you data that is really useful for a whole range of public health questions. So part of it is when thinking about relationships, public-private partnerships, is being really honest about like, what do we actually need? What are the minimum data requirements? Because it's not all your data, give it to us, make it open, right? All the legalities and morals aside, it's quite simple and it's specific, and often it's really not going to risk subscriber privacy or anything like that. So that's part of it. And then the other thing is the success that we've had is that there's a sort of forward-looking companies who want to invest in in the countries where they're working for the long term. But obviously they do like the opportunity to say we're doing good, and so there is a PR case for companies to do that, short of forcing them because it's the right thing to do. So getting the specifications and requirements accurate, and and then kind of working with companies to help them engage with their population and show that they're trying to do good has been my...
Thank you. I don't want to cut you off, but I do want to get in one more question before lunch, so I'm going to offer it. Sorry.
So I would like to ask about the utility of using modeling to know how to educate parts of our population so that they change their behavior and slow down the spread of influenza. Things that children learn in school, like coughing into their elbows instead of their hand washing, and a host of things, getting flu shots, that there are large segments of the United States population that doesn't believe in flu shots or hand washing or not shaking hands. And is there a way to use modeling to find out where these people are and how to get education to them?
I think this is me. So, at CDC, I'm responsible both for influenza and for routine childhood immunization. And I think flu is a great sort of place to frame this, because the hard thing with flu is we have to convince people every year to get an imperfect vaccine year after year. And it is incredibly difficult. If it was easy, we would have done it by now, right? And I do think that you're right. It's about understanding why people aren't getting vaccinated at a local level and helping to change their minds. It's not a national solution. Me or any of my colleagues standing up in an auditorium telling people to get vaccinated, except for my parents, isn't really going to get people showing up in droves. I think we influence people one person at a time, but in terms of at a population level, it's not that kind of solution. And I think my colleagues who do behavioral health would tell you that education isn't behavior change, right? Behavior change is more than just education, and it is a lot influenced by the social media, the social milieu around people. Childhood immunization coverage is much higher than adult coverage. Why is that? Because parents bring their kids in for healthcare. Adults, only 50% of them are getting vaccinated, and half of those are getting vaccinated in the doctor's office. The rest of those are getting vaccinated either at pharmacies or in their healthcare setting. But across any vaccine, including influenza, but also all the childhood vaccines, the number one influencer of whether people get vaccinated is your healthcare provider. And so in the end, even through all of the cacophony of social media voices, it is the trust between a healthcare provider and a patient that leads them to get vaccinated. We find disappointingly that though healthcare workers say that they're making strong recommendations for vaccination, if you listen in the interchange between a provider and the patient, frequently the providers are suboptimally educated about the importance of influenza vaccine, so they're not making strong recommendations. Turns out that even if the healthcare worker isn't the one giving the vaccine, the healthcare worker recommendation is still the strongest predictor of whether someone's going to go on to get vaccinated. So for me, while we'll keep talking to the public in general, where I really think we need to be working is at the healthcare provider level. And it's not just the doctor, it's every level of that organization. We released data this week on healthcare worker vaccination coverage against flu in the US last year. The actual numbers are actually pretty good. Most healthcare workers are getting vaccinated, but clinicians are much more likely to get vaccinated than the office workers at the front desk. And what you don't realize is that those office workers who are the ones greeting the patients actually can have a profound influence on whether they're getting vaccinated or not. So we need to also think beyond narrowly how we define healthcare provider and educate all the folks that are interacting with patients. That's how I think we're going to get influenza vaccination coverage up. Sorry, that was a long answer. But
Thank you, Nancy. I want to thank all of the panelists here for great presentations and good answers to questions, and thank all of you for being here. And let's get us ready for lunch. Thank you.